Hello everyone, I'm Dr. Abraham. Today we shall take a look at this common skin condition. We call it Asteatotic Eczema, and I think if you're Ugandan or if you've been keen, this is a condition that we commonly see in people living in rural areas, people who actually don't moisturize their skin, in elderly. So it's a common condition, and this is what brings it about and how to deal with it. So in this session, we shall see what we call asteatotic eczema, and it has different names. It has been called eczema craquelle, and in the white, it has also been given the other names like winter eczema. It has also been called the winter itch, and it was first described by a scientist called Gross in the 1940s. And commonly, we see it in individuals who have actually had enough time on Earth, who are about 60 years and above, and it is worsened by the environmental factors, including things like climate, things like low humidity, and what someone uses on their routine skincare. So we define it as a form of eczema that is due to extremely dry skin, especially in the older patients. And it has causes ranging from exogenous causes, which include dry climate, low humidity, soap and water, and also sometimes malnutrition can also give you a similar picture. Endogenous causes can include things like aging, renal insufficiency, patients with chronic kidney disease, other hereditary conditions like Escherichia vulgaris or even atopic dermatitis can give you a dry skin, which we call asteatotic eczema. So it's a little bit rare, but sometimes it can also be seen in patients who have a systemic malignancies like lymphomas, and in this case, it will be widespread over the body and very, very hard to treat. So in the key points that we have to note how it comes about, this is an entity that has been shown to be due to a decreased stratum corneum functioning or epidermal barrier dysfunction. And in this case, you have decreased lipids and essential fatty acids that are supposed to actually moisturize the skin. And then you also have unaltered lipid to natural moisturizing factor ratio. In this case, if you change, because they have to occur in a particular balance, in a particular ratio of lipids, and then also the protein quote that you see in the stratum corneum. So if you have a disarray or disarrangement or a disorganized or an imbalance in these ratios, then you end up with actual dry skin. So things like the natural urea, the fragrant protein, the ceramides, if you alter their concentration in skin, you can actually end up with a dry skin, which you see in this case, in this type of eczema. So when you look at the structural changes that you see that the corneocytes, instead of them being lost easily, actually they persist. You know that we are supposed to have a turnover every after 28 days. A cell is lost, actually it moves from the basal cell layer of the epidermis through the spinous layer, granulus layer, and then the stratum corneum. And it takes about 14 days for cell to be lost from the stratum corneum to the environment. So in this case, the cells will hang around more because of the persistence of the corneodesmosomes or those cell junctions that are supposed to actually let loose of these particular dead cells. So they stick around and then end up causing a pile of these dead cells that gives rise to the thickening and dryness that you see. And remember, because of the altered lipids that you see in this condition, you end up having the skin becoming a little bit cracked, rough, and scaly. And in the symptomatology, we see if it is in mild cases, we see just a mild xerosis, which can either be asymptomatic, someone just has a basically dry skin. But in case it becomes severe, someone may present with things like itching, stinging, or even is the irritation of the skin. So still, you can have inflammation being triggered, which is usually most times subclinical. This can involve production of inflammatory cytokines, and the scratching and irritants can easily access the skin to trigger these events. So we can have exacerbating factors. For example, we can have the edema-related eczema craquelle, or asteatotic eczema. This is a little bit more resistant, especially in patients who have other comorbidities that can give you edema. So things like liver failure, renal failure, heart failure, which can come with edema, can also give you this type of eczema crackle that may be very, very resistant to treat. So we can have, in the pathogenesis, we have what we call the sodium conium dysfunction and the lipid imbalance. And then in this case, you'll have the key points being reduced essential lipids in the skin, especially the cholesterol, the ceramides, and the free fatty acids. Their concentration will actually reduce. This can occur as a natural process of aging, but sometimes dry environments like the tropics, the low humidity can worsen or can precipitate to someone developing this condition. Then you have also reduced uh, uh, functioning of these fatty acids. So meaning that they cannot retain a lot of moisture, so the skin will be eventually dry. Then you can also have what you call the altered lipid ratio. This one I've talked about it already. So you know that you have to have a balance between the ceramides and then the fatty acids. But in this case, someone will have reduced ceramide 1 levels, and this gives an imbalance that ends up favoring dehydration more than hydration of the skin. So the lack of this ceramide disrupts the lipid matrix, and this impairs the protective barrier as well as promotes dehydration of the skin, giving rise to a very, very dry or xerotic skin. So we also have a reduction in the natural moisturizing factor as someone ages. In this case, we have reduced urea, lactic acid, and amino acids from fragrine gene or protein. And we know some of these amino acids like histidine usually helps you to absorb and keep moisture in the skin. So if you lose it, meaning that your ability to keep moisture in the skin also deteriorates, and that gives rise to a very, very dry skin. And we see that as you grow, you have an impaired or weakened barrier function, and then this also triggers an inflammatory cascade that gives now rise to the use of cytokines that worsen the situation. So as you're having nutrients from the environment, they together with the reduced barrier function, then you have other things exacerbating like the dry environment and the rest. Then you have easily irritated skin that gives rise to what we see. So how is the clinical picture in asteatotic eczema? So initially, the distribution will affect typically the shins. We'll start from the shins of the legs. Then later on, as the condition worsens, we can see it on the hands and the rest of the body on the trunk. But oftentimes, it will spare the face because the face usually has more dense sebaceous glands. So it will be well moisturized compared to the rest of the body. And also, it will spare the palms and soles. And then you will see that in the early stages, someone will have maybe a dry skin with a very dry, fine scale. And later on, they will now develop powdery scales with very clear-cut fissures, which we call the crisscross cracks and fissures that you see in the stratum corneum. And this usually resembles the paving. And some people say, oh, related to the dried liver bed. So in this case, the color will be either pink, that is in the people with lighter skin types, but in our case, it will be actually a little bit darker. And you see, like for example, you see here, this is the cracks that you see with this adherent scale that you see there. So that is how eczema crackle will look like. So this is the relationship that has been derived to show you that how it looks like. So this is a dried liver bed where you see these cracks on the liver bed when the water levels have gone down, and that's the same picture that you see on the skin. You see these cracks that come on the skin, and then this fine scaling that shows you that the skin is actually very, very dry. So how do we go about this? So in case someone has pruritus, we can give anti-itch medicines or like antihistamine to make them sleep nicely. But then topically, we can give the anti-inflammatory drugs that deal with the subclinical inflammation that comes with eczema crackle. And in this case, you can give the topical corticosteroid. You can start with medipotent like betamethasone valerate for a few days. When someone has improved, then you take them off the medicine. You can also give the topical calcium inhibitors like the tacrolimus, pimecrolimus. And then you also have now managed the cirrhosis with very strong emollients. You can use a emulsifying ointment which has pure pectolactam that tries to beef up the hydration of the skin. And this can be applied actually up to 4 to 5 times a day. You see, every time the skin is dry, the patient can reapply very many times. They don't need to bathe it more. And then you have to give other things like, you can give other things like urea, other things like ceramide-based moisturizing agent, other things like lactic acid that actually hydrate and moisturize the skin. They can also take oil baths where they can put things like olive oil in their bathing water to try and moisturize the skin or and prevent drying effect of the water. Then you have to prevent these relapses by eliminating the factors that aggravate the condition. So things like harsh soaps should be avoided. So they can go for gentle soaps that actually are hydrating. You can get soaps that actually have olive oil base and then oil bases that are added to the soap so that even when you're using the soap itself is actually moisturizing. Then you can also as well address the core existing morbidities, the hidden issues, the malignancies. When they resolve, usually also the skin gets better. So thank you very much. That was a short one of a video on asteatotic eczema, which we also call the eczema crackle. And this is a common finding in our elderly patients. So in case you've seen this before, this is one of the easiest dermatoses to manage. And you just moisturize the skin and the patient will be okay. Thank you very much. See you in the next video. Please remember to share, subscribe, and support the channel.